Good morning. This morning, we are going to do the examination of the abdominal system. With us here, we have Encik Nasrul as our patient. So first, we have to introduce ourselves to the patient. Encik Nasrul, selamat pagi. Today, we are going to examine your abdomen. I hope you don't mind.
No.
Okay. So for the positioning of the patient, we like the patient to be supine on one pillow and make him as comfortable as you can, and make sure that he's not cold or too hot. Okay. So the first part of the examination of the abdominal system will start with general examination. And we will have a look at the patient and see whether, what is his body build, whether he's very obese or whether he's undernourished, undernutrition. And we have also to look at his actual nutritional status, as well as his hydration status. We'll go into more detail later on, looking at his eyes and his lips and his skin turgor for the hydration status. And followed by looking at his skin, whether he is obviously anemic or whether he's obviously jaundiced, whether he has got any bruises on his arms or his legs, and also have a quick look at the lower limb and see whether there's any edema of the dependent part on the legs. And also the other aspect of the general examination will be the surrounding of the patient. By surrounding, I mean whether he has got an IV line attached to him, whether he has got continuous bladder drainage with a catheter, or whether he has got a drain. For example, those patients who had just an operation, they may have an abdominal drain. So these are all the points that we should take note of when we start the examination of the abdomen. The next stage of the examination will be that of the hands as well as the arm. First, we have a look at the hands of the patient, and we look particularly at the fingernails of the patient and see whether there's any clubbing, okay, by looking at the angle of the nail, okay, and test for fluctuation. And we also look at the color of the nail, of course, whether there's any pallor, but also any leukonychia, which is whiteness of the nails. Look at the nails on both hands, the right and the left, as well as look at the shape of the nail. See whether there's any spoon-shaped nails. You have to feel the nail individually and see whether there's any depression. And that is called koilonychia, which is a sign of iron deficiency. So after looking at the nails and the fingers, we look at the back of the hand, okay, and we see whether there's any wasting of the interossei, and we turn the hand around and see whether there's any wasting of the tena and the hypotena eminence. The next thing will be to look at the color and see whether there's any liver palm or palmar erythema. The liver palm is seen at the tena eminence, the hypotena eminence across the palm, as well as the tip of the fingers, and they appear as redness, unusually red. And next, you look at whether there's any dupuytren contracture, which is across the middle of the palm, and you have to run your thumb or your fingers across the middle of the thumb and feel whether there's any hardening of the tendons, the dupuytren contracture. And after the dupuytren contracture, we go on to the next stage. Next, we look at whether the patient has got flapping tremors. In order to do that, we get the patient, Nasrul, put your hand up like that, to put up the hand like this with a little bit of hyperextension at the wrist. And we look particularly at the fingers and see whether the fingers actually flap forward. So if the finger does flap forward, after maybe a few seconds, then that is called a flapping tremors. And flapping tremors is indicative of liver failure. So after looking at the flapping tremors, thank you, we will look at the arms for any evidence of bruises, or ecchymosis, or whether he has got any AV fistula. We also would like to see his joints very quickly, go through the joints if there's any obvious sign of arthritis, because that may relate to intake of drugs like non-steroidal, and that may have an implication on the GI system. And also to look at in the upper arm here, whether there are any spider nevi. Now, spider nevi are better seen over the upper chest, but sometimes you do see them on the upper arm as well. And besides, you want to examine for the radial pulse and also take the blood pressure of the patient. Next, we examine the head and the neck of the patient. We'll look at the face of the patient and particularly noticing whether there's any wasting of the temporalis muscles. And we look at the eyes of the patient to see whether he has jaundice. Nasrud, can you please look at my finger here? And also to look whether there's any anemia of the conjunctiva. And occasionally, you may be able to spot the KF ring or Kaiser fracture ring, but it is better to be seen under a slit lamp. So after examining the eyes, the next thing we want to do is look at the lips and the mouth, as well as the tongue of the patient. The lips and the mouth to particularly look for angular stomatitis at the angle of the mouth. Can you open your mouth? Yeah. And you have a quick look at his teeth as well as his tongue. Show me your tongue, please. Yeah, further up. Yep. And in the tongue, you actually notice the color of the tongue, whether there's any pallor indicative of anemia, and also whether he's well hydrated or whether he's dehydrated. Okay, so you can close your mouth. Thank you. And then after examination of the head, mainly the face, we go on to examine the neck of the patient. Next, we look at the neck of the patient and we look for any obvious pulsation, either venous or arterial pulsation on both sides. And we look for any obvious swelling that we may see, either the thyroid or any lymph nodes that we may see on both sides of the neck. And we'll go on to examine, to palpate for any lymph nodes. And we will start from the angle of the jaw and we move down the neck on one side first and then on the other side, looking for lymph nodes. The best way of examining for lymph nodes in the neck will be to get the patient to sit up. Please. So when we examine the lymph nodes from the back, we'll again start from the angle of the jaw and we move down and see whether we can feel any lymph nodes along the cervical chain. But emphasis have to be focused on the Virchow nodes, which is at the left side in the supraclavicular fossa medially. Okay, and this is the area where we look for Virchow nodes. The next examination will be that of the chest. So we will inspect the chest, especially the upper chest, and look for any spider nevi. Spider nevi are small reddened spots that actually look a bit like a spider, and they are best found in the upper chest above the nipple line, and sometimes you see it in the upper arm, as well as at the back of the chest. And what you should do is, when you look at a suspicious lesion, you should press the tip of your finger over the center of the lesion and see whether the whole lesion disappears. In spider nevi, the whole lesion will disappear with pressure in the middle. And besides spiders, you want to look at other lesions that can be seen on the chest. For example, this patient has got a pigmented lesion over the upper chest on the right side. And the next examination will be that of the breast, and to see if the patient has got enlargement of the breast in a male patient, and that's called gynecomastia. Now, gynecomastia is confirmed by palpating for the breast tissue in the so-called enlarged breast and see whether it's actually the breast tissue or whether it was just fat. And after examining the breast, we would like to have a look at the armpit and to look for the axillary hair to see whether there's any loss of axillary hair. If there is loss of axillary hair, it may be indicative of chronic liver disease. Now we come to the examination of the abdomen proper. The first thing that I like to stress is adequate exposure of the patient. The clothes of the patient has to be folded up to expose minimum from the cervicasternum, even better if it is higher than that, and in the lower border should be pulled down to the level of the symphysis pubis, okay? So we can have a good inspection of the abdomen and later to palpate, etc. During inspection, we should put emphasis on any of the skin lesion that we may want to look for, particularly the striae. You know, you may have striae in women who had born children before. You may want to look at striae indicative of Cushing's. You also want to look for any scars, whether it is surgical scars due to previous operation or non-surgical scars. And also you look for any spots, the famous ones that we always see in the elderly patients are the red spots called the Campbell-De Morgan spots. And also sometimes in typhoid fever, you may see rose spot on the abdomen. Now, the next thing you look for will be any distended veins, okay, on the abdominal wall. If you do see distended veins, then you may have to decide on the flow of the blood. Either it is up towards the heart or down away from the heart. Now, next, you want to see the umbilicus. In this case, we see the umbilicus inverted, which is the normal person. But sometimes the umbilicus may be flush with the abdomen, or we call it flat umbilicus, or sometimes the umbilicus may be actually protruded or called everted umbilicus. The next thing we look at will be the shape of the abdomen, whether the shape is one of scaphoid, that is the name that we use to describe a normal shaped abdomen, scaphoid, or whether it is protuberant, that means it's, bulging out, or whether there's any obvious masses that you can see over the abdomen, and notice where is the obvious masses, whether it is in the right side or in the left side, the location of the mass. Besides, we also want to look for caput medusa, which is around the umbilicus. Now, the next thing we want to observe is to see whether the abdomen moves with respiration, which normally it does, okay? For example, now we can get the patient to breathe quietly in and out. We can see the abdomen moving with respiration. And the next thing is we will have to look for visible peristalsis. Now, peristalsis are normally not visible, but in certain condition, peristalsis can be visible, for example, in intestinal obstruction. So you can see the gut moving underneath the abdominal muscle if you are patient enough to watch for it. Now, the next thing is you look for any visible palpation of the abdomen. Now, in very thin individuals, sometimes the pulsation of the abdominal aorta can be visible on the middle of the abdomen. But if you do see a visible pulsation, the query will be whether it's one of abdominal aortic aneurysm. After inspection, we come to palpation of the abdomen. This can be done either with the examiner standing up or with the examiner sitting down on a chair, making sure that both the patient and examiners are comfortable, or even with the examiner kneeling down by the side of the patient to examine his abdomen. Obviously, you have to have a fairly low couch in order to do that. It is important to stress at the start of the examination of the abdomen that the patient has to be made very relaxed, and a quick look at the legs to make sure that he doesn't cross his legs. And it is also important to look at the face of the patient during the whole of the examination and watch for grimaces. Now, if patient has grimaces on his face, it's telling you that the patient is feeling pain, and you have to be more gentle in the examination. Now, the other point is that the examiner's hand have to be quite warm. It may not be a problem in this country, but if you happen to be examining in the aircon room, that you have to make sure that your hands are warm before you start putting your hands on the abdomen. And also that the hand should be slightly flexed at the MP joint. It's not flat like this, but slightly flexed at the MP joint. Now we start examining the abdomen by doing a light palpation. And we will systematically examine the 9 region of the abdomen. And we will look for 2 important aspects. One is the muscle tone. Either the patient is soft or rigid, or there is guarding, and also whether there's any tenderness in any part of the abdomen. After the light palpation, we go on to do a deep palpation. We can either use one hand or even more effectively using 2 hands like this. And at the same time, we get to the patient to breathe, opening his mouth and breathe. Nasrul, yeah, good, good. And try to follow his respiration. And when he expire, we actually try to move the hand deep in, like this. The purpose of the deep palpation is threefold. One is to, again, look for muscle tone, like what we did in light palpation. Second is to look for any tenderness. And third, and that's the most important, is to look for any organ enlargement or any deep-seated lesion that we may not have picked up in the light palpation. Now we will look specifically at the liver and palpate the liver, and we will start from the right iliac fossa and move the hand up to the right hypochondrium, and at the same time getting the patient to breathe. Nasru, please breathe. Open your mouth and breathe. Good. Yes. And we follow the breathing. When the patient expires, the hand will move down. When the patient inspires, the hand will move up. And if the liver is enlarged, then the edge of the enlarged liver will hit the index finger. If the liver is enlarged, we will then have to note the edge of the liver as whether it is sharp or whether it is rounded, whether it is irregular, and the surface of the liver, whether it is smooth or whether it's nodular or irregular, the consistency of the liver, whether it is soft or firm or hard, and also the size of the liver. So in order to assess the size of the liver, what we do is we will note the edge of the liver and take a tape measure along the mid-clavicular line, that's the nipple line, and then put a tape from the costal margin to the edge of the liver, and we note it in centimeter. Next, we will assess the liver span of the patient. In order to do that, we have to determine the upper border of the liver as well as the lower border. We probably will have known the lower border from the previous palpation, and we make a mental note of the lower border. The upper border will have to be decided by percussing the chest from perhaps the second space down, and note the change from the resonant to the dull tone of the liver. And again, we either make a mental assessment of where the upper border is and the lower border, and then we use a tape measure to measure the liver span like this, or we get the patient to help us to decide where is the lower border. Now, if we cannot be sure by palpation where is the lower border of the liver, we can also do it by percussion, by percussing upwards from the right iliac fossa. We'll normally hear the tympanic sound of the abdomen. When the sound changes into one of downers, that will be the lower border of the liver. The normal liver span is between 8 to 12 centimeter in a normal adult when it is measured along the mid-clavicular line. Next, we'll go for the spleen. And again, it is the same method as the liver, but now we will use the left hand to put behind the rib cage and slightly push it upwards. In a sense, we try to bring the spleen forward because spleen is mainly a posterior structure, and it enlarges this direction from the back to the front, and therefore it is important that we use the left hand to slightly lift the spleen up so that if it is enlarged, the right hand can feel it. Again, we have to ask the patient to open his mouth and breathe, and we will follow the breathing movement. And if the spleen is enlarged, the tip will hit the finger. It is important to emphasize, in order not to miss a spleen, we have to start the palpation from the right iliac fossa and work up towards the left hypochondrium. And when the spleen is enlarged, we will have to note the edge of the spleen to see whether it is sharp or rounded, to note the notch, the splenic notch, which characterizes the spleen, the surface of the spleen, whether it's smooth or whether it's nodular, and tenderness, and also the size of the spleen. Now, in order to measure the splenic enlargement, we will measure again from the costal margin to the tip of the enlarged spleen. If the spleen is not palpable, then we have to percuss and note if there's any downers in the throat space, which is here. Noting that the spleen, it has to be at least twice the size of the normal spleen before we can palpate the spleen. Next, we go on to palpate the kidneys. We have got two kidneys, one on the right and one on the left, and we need to use the bimanual technique. In other words, using two hands to palpate for the kidney. Again, we ask the patient to breathe deeply through his mouth, and we use the left hand to lift up the kidney, so to speak. And if the kidney is enlarged, we will get the left hand to jerk the kidney forward, and when the kidney is jerked forward, it will hit the right hand. And we will note if the kidney is palpable, whether it is, has got a smooth surface, whether it is tender, how big the size is. The kidney is rounded in shape, so you get a rounded structure hitting your hand. So we do the similar examination on the right side as well, putting the left hand behind and getting the patient to breathe in and out, and trying to push the kidney or jerk the kidney forward from behind, so that if it is palpable, it will hit the right hand. It is important to make a point to say that palpation of the kidney is usually best done when the patient is in the expiration phase, whereas the liver and the spleen will be best at the inspiration phase. After palpation of the liver and the spleen and the kidney, we'll move on to feel for other masses, for example, enlarged lymph nodes, para-aortic lymph nodes, and any other masses that may be palpable when examining the abdomen. When we complete the examination of the abdomen, we will move down to look at the groin, the inguinal region, and in particular, we will look for the any palpable inguinal lymph nodes. And we also will feel for the femoral pulses on both sides. And also we'll look out for any obvious hernia in the inguinal or the femoral region. The next step in the examination of the abdominal system is percussion. And to percuss, you have to use the middle finger of the right hand and percuss against the middle finger of the left hand. And the normal abdomen is tympanitic because it is filled with gas. If there is abdominal swelling, we have to decide whether the swelling is due to gas, which is tympanitic, or whether it is due to fluid, then it will be dull, or it is due to a solid mass, again it is dull. So the percussion will help us to decide the nature of the swelling. If we have a suspicion that the patient has got ascites, which is fluid in the peritoneal cavity, then we will examine the patient using this technique called shifting downers. In order to do that, we start in the middle of the abdomen, like this, and we will percuss the abdomen, moving towards the left side or towards the right side. It is usually better towards the left side until we hit downers. When we hit downers, we know that is fluid there. Now we turn the patient over. Nasru, please. And then we will wait for a short while, and we percuss now from where the finger was, and then go back down to the middle and see whether the downers has shifted down. If there's fluid, the downers will then shift down to the dependent part of the abdomen. So once you hit the downers, you know that there's fluid in the peritoneal cavity, and this sign is called shifting downers. If we have a large ascites, we may be able to demonstrate another sign, which is called fluid trill. In order to do that, the left hand is put on the left flank of the patient, and the right index finger will flick on the right side of the abdomen. And if there's ascites, there will be a shock wave transmitted to the left hand. In order to distinguish that this shock wave is not transmitted because of ripple through the abdominal fat and skin, we get the patient to put the hand in the middle to block off this ripple, and we again use the left hand and the right index finger to flick and see whether we can elicit a fluid trill. And after we have done this examination, this will be the end of the percussion for examination of the abdominal system. If the patient has presented with abdominal pain of acute onset, especially abdominal pain on the right side, then it is important to look for the gallbladder. Now the gallbladder, of course, is in the right hypochondrium, and the same technique as palpating for the liver applies here, is to palpate from the right iliac fossa upwards, getting the patient to breathe, opening his mouth, breathing in and out, and feeling for the gallbladder. And with the respiratory movement, an enlarged gallbladder will hit the finger. Now, the enlarged gallbladder, of course, has got a rounded border. If the gallbladder is not palpable, then we will elicit the Murphy's sign. Now, in this sign, we will get the patient again to breathe very deeply, and the hand will be compressed very deeply as well. And if the patient suddenly stops in mid-inspiration, then it is a positive Murphy's sign, indicating acute cholecystitis. If we have a jaundice patient, patient with obstructive jaundice, it is important to include examination for the gallbladder in the abdominal examination. It is to feel for the presence of a gallbladder, just like when we examine for the liver, moving from the right iliac fossa upwards and getting the patient to breathe in and out. If the gallbladder is enlarged in the presence of deep jaundice, an obstructive jaundice, then the Courvoisier law applies. The Courvoisier law states that if the gallbladder is palpable in the case of obstructive jaundice, then we are dealing with a malignancy. We now come to the last part of the examination, That is auscultation after the inspection, palpation, and percussion. And we can use either the diaphragm or the bell of the stethoscope to do that. In a person who is not very hairy, you can use either, but in a very hairy person, it may be better to use the bell to auscultate the abdomen. So what do we do with auscultation? We actually listen for bowel sound. Now, bowel sound is not like heart sound. Bowel sound is slower, and you may take a longer time to listen to bowel sound. And you want to note the character of the bowel sound, the intensity, whether it's loud or soft, and also the frequency of the bowel sound, because it is important in certain abdominal condition, in abdominal pain, for example. And the next thing we want to examine with the use of the stethoscope is to examine enlarged liver or any enlarged masses or any palpable masses, and we look for bruit. Now, bruit is, of course, same timing as the heartbeat, and it just indicates to you that the organ or the mass that is giving rise to the bruit has got an increased vascularity. So you again put your bell or your diaphragm over the mass and you listen for at least half a minute for the presence of bruit. So besides listening for bruit in the liver or any other masses, in patients who are hypertensive, you may want to also listen for renal bruit. Now, renal bruit, of course, is best heard over the upper part of the abdomen, corresponding to the level of the renal artery. Again, you put your bell over the abdomen, and in this case, you have to probably compress it because the renal artery is quite deep down in order to listen to get the bruit over the renal artery, and that's called the renal bruit. So with this, we would have completed the examination of the abdomen.